Good afternoon. Welcome to all the delegates and the distinguished faculty on this instruction course on customizing multifocals to patient profile for optimal results. As we know, nowadays, if you ask a patient whether he wants the entire range of vision, definitely most of them would want it. But then what was preventing us from offering multifocal IOLs to more number of patients was, one was the cost of the IOL. The second is the photic phenomenon which was available. And third is the customization with related to the functional near and intermediate vision the patient had. So now with the available gamut of lenses from the varying cost aspects, we are able to give and offer multifocality to a larger number of patients. So this talk is basically on how to customize the multifocal to the patient profile. And we have an excellent array of stalwarts in this field of intraocular lens implant and multifocal lenses. So we have Dr. Sandhya N, who is a senior consultant cataract surgeon at the Giridhar Eye Institute. We have Dr. Mohan Rajan, an excellent cataract surgeon from Rajan Eye Care Hospital, Chennai. Dr. Chitra Ramurthy, Director, Eye Foundation Group of Hospitals. Dr. Elakkumbaran, Navshakti Netralaya, Bangalore. Dr. Minu Mathan, who is a prolific cataract and refractive surgeon from Chaitanya Institute, and myself. So let me call upon Dr. Sandhya N to talk on the platter to choose from. Over to Dr. Sandhya.
Thank you, Dr. Sony, for the opportunity. Now, multifocal intraocular lenses, the platter to choose from. Now, when we are young, we can see at all distances because of accommodation. And but after pseudophakia, there is total loss of accommodation. So how can we give multifocality to our patients, pseudophakic patients? We have three options: monovision, multifocal IOLs, and accommodative IOLs. I'll be dealing with multifocal intraocular lenses. So these lenses, they give two or more focal points. So mainly they are of two types, refractive and diffractive. In diffractive, we have bifocals, trifocals, and extended depth of focus intraocular lenses. So refractive lenses, they have multiple rings on the optic, and each of these rings will focus light at a particular focal point. So these lenses were pupil and centration dependent, and the photic phenomenon was high, so they didn't gain popularity. Now coming to the diffractive lenses, they have multiple diffractive steps on the optic, and each of these steps from the periphery to the center focus light at two different focal points, that is one for distance and one for near. And these steps, according to the width of the step, that determine the adhesion. Narrower the step, the higher the adhesion, and when the height of the step was more light entered the eye. So these lenses, they had less halos and glare, but the intermediate vision was not great with these lenses. Now then came the concept of apodization, where there was gradual tapering of refractive steps from the center to the edge of the optic to give a smooth transition of light from distance to intermediate to near. Now the traditional multifocal lenses were bifocal lenses. They had two focal points, one for far and one for near at around 30 to 40 centimeters. They gave excellent distant vision and near vision, but compromised intermediate vision. So these lenses, they've divided the light, they split the light, that is 40% for distance and 40% for near, and the remaining 18 to 20% of the lights were dispersed, that is scattered or lost, and this produced the glare. And since they had two focal points, at each of these points, they had a second superimposed image from the first one. So there was halos around the light, and this was the their disadvantage. Now, these were the commonly used available bifocal lenses. Now, most of them are becoming out of practice now. Now, coming to the newer generation multifocal IOLs, first we have extended depth of focus lenses. Okay, these lenses, they created an elongated continuous range of focus to enhance the depth of focus, contrary to monofocal lenses which had a single sharp focal point and bifocals which had two focal points. Now, the pure EDOF lenses, they employed either the spherical aberration-based optics or the pinhole effect. And then we had hybrid EDOF lenses, which employed the chromatic aberration, or they had a diffractive hybrid profile. Now, these lenses, they gave good distant and intermediate vision, but the near vision was not great. And since they didn't have separate focal points, they had less photic phenomena, but the trade-off was because of the less light, the contrast sensitivity was poor. Now, this is a lens that uses increased spherical aberration. That is, you can see as the spherical aberration range increases, the depth of focus also increases. Now, another type of EDOF lens is that using pinhole effect. It uses an opaque pinhole to mask in a monofocal IOL that will increase the depth of focus because it will cut off the unwanted paraxial light. So, one such lens was IC8. Now, coming to yet another lens, that is Technis Symphony, which was a hybrid EDOF lens. It used the H-Lite technology. That means there was modification of the height, spacing, and the profile of these diffractive steps, so which provided the extended range of focus. And these were the toric lenses were also available, correcting 0.6 to 4 diopters of astigmatism. Now, another lens was Supraphobe in focus by Appasamy. It was basically a bifocal refractive lens with an EDOF profile. Now, coming to another one, that is VVT. It is a smooth surface transition element which stretches and shifts the wavefront to create an EDOF effect. Now, these were the commonly available EDOF lenses, and we have the lenses from Indian companies like Supraphobe in focus and Magnificent by the Care Group. And another lens, that is Technis Eyehance lens. I would call it a Superman monofocal lenses because this is basically a monofocal lens, but it gives intermediate vision up to the range of 66 centimeters. This extended depth is given by a smooth continuous progression of its power from the periphery to the center with no demarcation line. And the advantage of this lens was the photic phenomena that was less, and this could be implanted. Since it is a monofocal lens, it could be implanted in patients who are not ideal candidates for multifocal because of either some macular lesions or other ocular pathologies. So, such people, we could offer these lenses, at least they could have some intermediate vision. Now, next in the spectrum is trifocal lenses. They had 3 distinct focal points, one for distance, intermediate, and then for near. And they had improved visual quality because the light transmittance was good, but the photic phenomena was comparatively less with these lenses. Now, these are the commonly available trifocal lenses. That is the fine vision, AT-LISA, Panoptix, and Tridiff. Of these, most of these lenses, they gave near vision in the range of 39 to 42 centimeters. The intermediate vision of most of these lenses were 80 centimeters, but for Panoptix, it was 60. So, they had high light transmittance of about 86 to 88%. So, the distant vision was not much compromised. Now, the last in the spectrum is the continuous range of vision lenses. See, if you can see this here with my bifocal lenses, it had a distant focus and a near focus, but there was a gap in the center. Then with trifocal lenses, the distance, intermediate, and the near vision was good, but the junctions, there was a gap. So, in these junctions, what they employed was they employed the EDOF technology to give a continuous range. So, one of such lenses is Synergy, and they have toric platform also with that. So, in summary, the traditional multifocals were bifocals. They gave good distant and near vision, and the intermediate vision was poor, but they had high photic phenomena, so they are slowly becoming out of practice. And the next is the EDOF lenses. For them, the distant vision and the intermediate vision was good, and the photic phenomena was comparatively less because they didn't have distinct focal points, but the trade-off was decreased contact sensitivity. And the trifocal lenses, they have comparatively less photic phenomena, and have a reasonably good distant, intermediate, and near vision. So we have to select from these platter for the better outcome of our patients. Thank you.
Thank you, Dr. Sandhya, for that explanation of the various kinds of multifocal and EDOF lenses which are available. Now, we'll move on to we'll take the questions last. We'll move on to the next talk by Dr. Mohan Rajan, The Way I Do It. Dr. Mohan Rajan is the director of Rajan Eye Care Hospital and is a prolific cataract and retinal surgeon. Over to you, Dr. Mohan.
Yeah. I think you should get the. Can you get the slides? Yes. Right. Okay. Thank you, Sony and KSOS. As I was telling the other all, past I think more than 2 decades I've been coming to Kerala State. Kerala is my second home. In fact, Sujata asked me whether I have a chinna video here. Okay. So it's so frequently I come to Kerala. Because of COVID only I was not able to come. Why the slides are like this? Okay. As you know, the most important thing in a multifocal lens is a premium. There's a golden I call it the golden triangle. The premium surgeon, the premium IOLs, and of course need to do the premium surgery as well consistently. The sun is setting on the old mindset of cataract surgery. We used to have patients who are 80-year-old with a dense nucleus, mature cataracts, and whatever you give, at the end of the day, they'll fall at your feet. But you have patients like younger patients coming with the 2+, 6/9, 6/6 vision. It's like a luxury patient, like a consumer, or the plastic surgery. Post-operative results, you need to give them good vision for distance, intermediate, as well as near as well. The 4 mantras as far as the cataract surgery is concerned is refractive, increase refractive accuracy, decrease the complications like corneal edema and PCR, and they choose the IOL that gives the best visual quality. And N6, please understand, N6 is not the goal. The goal is happy patients at the end of the day. So results exceed expectations. Okay, this set really, you cannot make this old lady after oculoplastic surgery like Aishwarya Rai. You can make her better than what. This is called realistic expectations. And you need to tell these patients at the beginning when you are doing the chat time. So what I tell the patient is, you look better, but not look when you are 21 years old. That is plastic surgery. What happened, man? Yeah, you'll see better, but not like when you're 21 years old. Under promise and over deliver. As far as multifocal lenses, we used to have refractive, diffractive. Okay, refractive, multifocal lenses, good far vision, intermediate vision, near vision, everything. But the problem with this is that there are a lot of glare and halos in this refractive multifocal lens. So we used to have night vision difficulties, decreased contrast, and this is a refractive multifocal lens, glare and halos. You can see significant glare, halos around headlights. Of course, the new generation multifocals is very, very less, but this can be very troublesome. So how many of you are using multifocal lenses regularly in this audience? Not many. Yeah, not many. Why? Because of this problem only. So you can see the music master Ilayaraja, I operated in 2007. Okay, at that time the Restore Plus 4 was available. That was the lens which is available, but it's quite unhappy because he is not able to see the intermediate vision. Okay, for him the intermediate vision is important because he has to play the piano. And Kapil Dev now is playing golf. He got operated in Delhi. He is not happy with this thing. You can see here, he uses glasses for that now. And Kapil Dev also is not very happy with the Restore Plus 4. Because the intermediate vision is what is very, very important nowadays. So multifocal lenses were meant for housewives, house husbands, and mother-in-law. Okay? But the problem is we have new generation IOLs. I think we are talking about, Sandhya was beautifully talking about unifocal plus lens. We call it high-ans lens. The EDOF lenses, VVT, Symphony, Lucidus, Infocus, trifocals are there, Panoptic, Synergy. So many other companies are coming out with newer technology and thing. Other IOLs, the new generations like Dhoni. I'll just quickly go through the high-ans lens. The advantage of the high-ans lens is that it's a good distance, intermediate, but near vision you need to wear glasses. Symphony lens again, good distance, intermediate, good contrast, near vision not very good. So you need to know the merits and demerits of each and every lens before you counsel the patient. Synergy lens, you give the continuous range of vision, good contrast, but the halos can be there. These are all ringed lenses. Please understand the ringed lenses are all the concentric rings, the diffractive lenses, some amount of glare and halos. All depends on the brain adaptation or multiple other factors. And it depends on the motivation of the patient as well. And very difficult to sometimes find out preoperatively. So again, the VVT, you know exactly. In-focus lens made by Apasamy is a very good lens, but the problem is the in-focus lenses that the near vision and the contrast is not so good, but still it's a fairly good lens. What is the new necessity? This is what I think is a game changer as far as multifocal in my practice is concerned. Good intermediate vision is what they want, not the near vision. You can see 2 to 2.5 feet, and you can see how I'm using the cell phone. It's about 2 to 2.5, which is about 60 to 80 centimeters. You can see the reading a newspaper in 2010, how this guy is reading a newspaper. How much it is? It is about 35 centimeters. How many people read a newspaper now buy a newspaper? They're all reading with the iPad or a tablet. So you can see the reading a newspaper in 2022, it totally changed, especially post-COVID. They're all not buying newspapers, and you can see the 60 centimeters is what is important. So again, you can see the number of people using mobile phone, number of people using the tablet and computers as well. Shift. You can see the newspaper, the sales in Chennai has come down from Hindu, 2010, 5 lakhs, 2018, it should have gone up because the population has gone up, 3 lakhs. Because in Times of India, 2010, 3 lakhs. What is the reason for that? The reason for that is, one reason is COVID. Another reason is that the people are now not buying newspapers because they're all reading newspapers on the iPad and tablet. So there's a shift in the near point from 35 centimeters to 60 centimeters, and this is again very important. So the main thing is which IOL for which patient. Okay, that is the question which everybody asks. Now we need to consistently hit the bullseye. So that is what is important. For that, I think we just did a course on the biometry. So you know, this is one of my very close friends. He's a golfer. You can see here, this golf, he needs good near vision. Good intermediate vision because he plays golf. Golfer, intermediate vision. So I was able to put a VVT lens. The patient very happy. Again, general surgeon. You can see the general surgeon because he's not driving. He's in the US. He's not driving. He's my cousin again, and a good. So he is very happy. So you know what is the requirement of the patient. What is your working distance? Whether he is doing night driving or something like that. So all these are very important. Again, this is a high myope. Okay, he's a high myope of about -15. He had cataract, and he's always used to high myopes. Please understand, they are all used to good near vision. So I went for a thickness multifocal +4 in one eye, +3.25 in another, because I wanted to give him good near vision. So the multifocal lens, he's at home, he's not driving, he's reading good newspaper, he's quite happy as well. Again, he's a hotelier from Andaman. You know how narrow the streets are in Andaman. So we put a VVT lens, and he's quite happy because glare halos are very less with these EDOF lenses are almost minimal. This is actually Dr. Gangadhar's mother, Gangadhar Sundar, who is an oculoplastic surgeon, and his mother is she's a social activist. She drives the car from morning to night, and she's having a symphony lens, very motivated patient. Very motivated patient, symphony patient, because the contrast sensitivity is very good. They don't mind wearing glasses, occasional glasses for reading. Happy panoptics patient, businessman, again, ophthalmologist from Russia. You can see, again, he's very happy with the synergy lens. Member of parliament, these politicians, you can do whatever you want, okay? Put whatever lenses you want. Again, eye trace is very important. Why eye trace is important? Because I do eye trace for all the patients. You need to know the angle alpha. If the angle alpha is more than 0.7, 0.8, then I go for a symphony lens, which has got a larger central diameter, which is about 1.4, then go for a thickness multifocal or a synergy lens or a panoptic lens. Again, a gynecologist, she wanted to know the difference between the ureter and uterus. She went for a symphony lens, and she's quite happy as well. She had a large angle alpha. And again, SP Balasubramaniam, he's a great guy. Okay, we put symphony lens because he wanted more of intermediate vision. You can see. So you based on customize your multifocal depending on whatever this thing is the patient is asking for. So it is very important how much they work. Again, my PhD guide, and again optometrist from Australia, and he was very happy with the synergy this thing. What do you do for this guy? Can anybody make a guess? Superstar. He's due for a cataract surgery with me. What do you do for this guy? Okay. Yes, no. Problem is he's got a epiretinal membrane in the macula. He has got an epiretinal property, old BRVO. So we will not, look at the OCT. OCT for all patients I do. All patients I do. Look at the OCT. Sometimes you can dense cataract, you can miss an ERM, can you miss a macular hole as well, LMH, or something like that. So look at the OCT. He's got an ERM. He will not be happy with the with any of the EDOF lenses or the Cinesive. I'm going to put probably an IANS lens for him. He doesn't mind wearing glasses for reading. So which IOL? Traditional IOL. So many IOLs are. Which IOL do you want? Okay. So many IOLs are there. But you do a math. So very important is you do a math and find out what exactly is the patient requirement. There are a lot of IOLs available. You know, Sandhya has beautifully mentioned the qualities, the merits and demerits of each and every IOL. You do a math and sit down with the patient. The counseling has to be done by you. That's what I do. I sit down with the patient, counsel the patient, and find out and push them for the femto or the catalyst or the synergy lens or symphony lens or panoptics or whatever it is. So the new generation IOLs and the current generation IOLs are there, and for everybody to see, I think all the patients will be happy at the end of the day. But you do a math and do your homework properly, I'm sure the patient also will do very well. Thank you very much, Sony, for the wonderful opportunity.
Thank you very much, sir, for that elaborative and very depictive demonstration of how to customize the IOL.
Next talk is by Dr. Chitra Ramamurthy. Madam doesn't need any introduction. Her talk is on my modus operandi with multifocal intraocular lenses. Over to you, madam.
Very good morning to one and all of you. And the screen has to come on. My very special thanks to all the members of KSOS and especially Srini and all the organizing committee members for this wonderful opportunity to come back to Kerala and be with all of you. So I'm going to go on a rapid race to try to explain about how I would look at customizing multifocals based on the patient profile. We all understand that a difference between a good surgeon and an average surgeon is if you are able to hit target emmetropia for your patient for whatever visual distance he wants, you are a success. And if you have not been able to be within plus minus 0.5, you actually have to be prepared that you are not actually a success. There were a lot of barriers in the adoption of the lenses in the earlier years, but in the last couple of years or more, there has been a significant trend for movement towards premium IOLs, and the doctors need to understand that there has come time for us to move more towards the premium IOLs because of the promises of biometry, because of the IOL designs, and because of our surgical prowess and understanding surgery as a whole. When we talk of multifocality, whenever an object of light hits a lens, hits a surface, there is a light distribution to give multifocality for distance with the power on the anterior and the posterior cornea and the zero order of refraction and for distance. And for near, it's the same for the power of the anterior and the posterior surface of the cornea and the first order of refraction. But while all this is happening, in the bifocal lenses, there was 20% of the light which was lost, and it was this which was causing the halos and the glare. We also know that the multifocal IOLs work on the principle of simultaneous vision. That is, when one image is in focus, the other out of focus image is which causes halos. So these were the different reasons why many of the surgeons were still off multifocals. But I think we need to understand that one size doesn't fit all and look at our patients. And for that, we need to understand the performance of these lenses. That is the defocus curve of these lenses, and not look at the modulation transfer function or those theoretical Air Force bar targets. What is defocus function curve tells us that after a particular lens is implanted in the eye, you give him the correction for distant vision so that he sees it clearly. Then you keep adding 0.5 diopters on the spectacle frame to defocus that image, but yet keep seeing his ability to read. That is, if a +1 diopter is placed in his lens, it is at what is he is perceiving at 1 meter. If a 4 diopter lens is placed, it's what he is perceiving at 25, and you are able to judge what is the range of vision that lens promises, and then compare the defocus curve of the different multifocal lenses and decide what you're going to offer your patient. You need to do an ideal pre-op evaluation. You need to give that chair time. You need to tell the patient that yes, you will give him freedom from range of vision, but it may have some trade-offs, but you could promise him that neural adaptation would help. You have to go through all of it, the ocular surface, the tear film, the refraction, the lens position, the retina, every bit of it. If you have access to mammography, even go ahead and look at the tear film, look at the hyperosmolarity, treat the dry eye, and then do your biometry. It is very important to do the OCT macula, rule out an ERM, lamellar hole, everything which could hinder him, which could hinder the contrast, and accordingly decide whether you're going to go for multifocality. You need to promise yourself that you need to treat the astigmatism when you're doing a multifocal lens, because it is not forgiving at all. So then you have a diffractive trifocal, an EDOF, or a mix and match. Of course, you have to do a perfect surgery. There's no second thoughts. So what is it about trifocal? Trifocal has 3 distinct foci, far, intermediate, and near. And nowadays, these present-day lenses do promise that the extent of dysphotopsia is relatively less. So if you look at this case, a young middle-aged man, he is not concerned about the dysphotopsia, but he wants independence for distance. Then you look at the astigmatism, 0.74, 0.59. These need correction, and you know that post-op astigmatism in enemy. So if you are on a femtocataract platform, do an arcade keratotomy, because you have a real-time OCT, you have the pachymetry, you have the topography to do justice to this small astigmatism, treat him and get him rid of it, and he did well. Now we also need to understand, like Mohan had said, that the intermediate vision has changed. It's no longer 60. There are many of our requirements 40, many of our requirements have come to 60 centimeters. So then, what are the trifocals we have in the market? We have AT LASER, which has an intermediate at 80. We have Physiol with an intermediate vision at 80 centimeters. We have PanOptics, which gets better, promising an intermediate at 60. So what is this about PanOptics? Besides that, it has a very optimal refractive zone of 4.5, which caters to both distance and near vision in an optimal manner. It has an intermediate of +2 diopters, and importantly, it has 88% light transmission. So more of the light is being utilized in the modern multifocals. And what, I'm not going to go into the details because of the paucity of time, but the conventional trifocals had 2 focal lengths, which was 40, 80, and infinity. And then PanOptics, what they did was, they had a 40, they had 3 focal lengths, which was an enlightened way of doing it, wherein they had 140, and then double of it, 1.5 times of it was 60, and then they had 120 and beyond. This 120, which was a 3rd focal length, was redistributed to distance, so that finally they had a 40 for near, 60 for intermediate, and for infinity. So then you need to compare the defocus of all these trifocals and compare, and you realize that they do pretty well. Only thing, the clarity of vision at 60 is better for PanOptics. 80, when many patients are happy, fine, they take that as intermediate vision. Then came the continuous range of vision. The promises here were a little more, in the sense it did not have distinct foci, but gave us a continuous range of vision. In other words, synergy seemed to answer this, wherein it combined a symphony and a diffractive multifocal and an extended depth of focus lens. That is, a symphony in combination with synergy. The symphony part took care of the distance and intermediate. The synergy part took care of the near and intermediate, so that they managed to give that extended range of vision. Besides that, what it also promised was a correction of the spherical aberration, reduction of the chromatic aberration, and also violet blocking specifically was done, which took care that the scatter of the light was taken care of, and also all those visual disturbances were taken care of, but you kept the blue light so that you were able to maintain good contrast and also a circadian rhythm. So then going further, so this was what the synergy. So this was a second patient who was okay for wearing occasional readers, then why not look at a Vivity for him? Because Vivity had that shift and stretch kind of, it had a little bump of 1 micron and a 50 micron of curvature change, which gave him that kind of a sweet spot at plus 0.50. So a little more add was, near add was, intermediate add was possible, but again it did not have that. It was a non-diffractive lens, and it seemed to be an answer for those patients who want great vision for distance, a little more for near, and little more for, not near, little more for intermediate, more than what eye-hands would promise. So then came the Symphony. What was Symphony doing here? Symphony is, of course, giving great vision for distance, intermediate, and not so satisfactory for near, but this man didn't mind an occasional reader. More importantly, it was 92% of light distribution was taken in, which gave an enhanced contrast because of the design of the height differentials which were there on the Symphony lens. It ensured there was a greater depth of focus, greater contrast, and a high light utilization, which augured that there was less of dysphotopsia symptoms. So then you compare the defocus curve of the extended depth of lens, the trifocal, and the continuous range of vision, and then you understand even better. Yes, trifocal gives crisp vision for distance, intermediate, and near. You are ready for a continuous range of vision, but you want a little more of near, go for something like a Synergy, because it has a near point at 33 centimeters itself, but you don't mind other lenses. Symphony, you don't mind wearing reading glasses. Now, if a post-LASIK patient, I would look at his topography, I would look at his eye trace to look at the angle alpha, which was said. I would try to look whether there is no other, higher order aberrations are within limit. And then I would suggest a Symphony for him in these eyes. Of course, I would use my Barrett's TK TK value for him. And this kind of patients do well with Symphony. Taking you further, if we had a glaucoma patient, or he has an RNFL field defect, he has already a poor contrast vision, then I might look at a monofocal lens or an enhanced focal lens. I would do a mix and match. I might give him a panoptics for his non-dominant eye and give him a Vivity in his dominant eye and keep him happy. But if he's not happy with the first eye, I might go slow on my strategy. Make him settle down, then do the other eye. If the patient feels that you could even do a micro monovision, make the second eye a little myopic. You could do a blended vision. You could do a monofocal itself, make the second eye myopic by 0.75. Don't make it myopic by 1, because more than 0.75, there's a loss of binocularity, stereopsis, and contrast. So just a little more myopic, and they also do well. You could do a variety of issues, like this was a Symphony patient in one eye. He was not happy for reading, so we could give him a Technis +4 in the other eye. This was a patient who had a small residual error. He was happy. Don't meddle with him. He's a happy guy with his 6'6", not so 6'6" patient. And again, so these are the important issues. And finally, there may be patients who have had a monofocal and have come back to you later for a multifocality. Today we have those Sulcoflex multifocal lenses which you could implant in these eyes and get him a multifocal vision. So most importantly, you need to look at the tried and tested platforms. Take feedbacks from your colleagues. Wait for your time. But believe me, today multifocality has come to stay. In 10 minutes, I know I rushed you through a lot of physics or lens designs and everything, but please let us all go back to understand that even the Indian multifocals today are doing well. Why? Because our biometry is bang on, our surgical designs, our surgical techniques are good, the IOL designs are good, so let us all definitely try to make our surgical technique as premium as possible. Thank you. I'm not supposed to show the slide. Cut it off. Cut it off. Thank you.
Thank you, Dr. Chitra, for that elaborate talk with a lot of examples. Thank you very much. I call upon Dr. Minu Mathan. He also doesn't need any introduction. He's a senior cataract surgeon at Chaitanya Eye Hospital, and his talk is how I look at it. In the meanwhile, can I request Dr. Safrullah to hand over the participation certificate to Dr. Chitra Damu.
Yes, 12:30. So good afternoon, ladies and gentlemen. Thank you, Sony, for this opportunity. So after this half an hour of listening to multifocals from stalwarts and great speakers, what more to say? Multifocal, people want multifocal, please put multifocal. What else to say? Everything about the technology, everything about how it is done, it's all already told. But then let me go down to, he has told me how I look at it. So How I look at it is in my practice. So practice varies. Type of patient varies. Chennai is different, Coimbatore is different, Trivandrum is different, Calicut is different. People are same, but then how people see, I am sitting in in Trivandrum, which is the headquarter of Kerala. It's the biggest, one of the biggest private hospitals with all even laser platform surgery. But whatever, said and done, around 80% of my patients are reimbursement patients. Cash payment patients are less than 20% patients. And it comes down to money, as far as I am concerned, for a majority of people, what they choose. And there are a group of patients who are brought by their children, relatives. And there are also two groups, children coming from outside and then want best, costliest, cost doesn't matter. The other one, their insurance, so let us stay within the insurance of what we have. So try to understand what these patients are coming for. That is the first thing we need to find out. So in a big practice, large volume practice, people keep coming, people get worked up, seen by the preliminary doctor, they come to me, and then you see cataract, advice, go to counseling, then they get counseled there. But then, till then it's fine. After that, if they opt for a premium or if they are asking for something other than what is available, which is all laid on the table, all options are laid on the table and it's everything is told in counseling, then they come back to me without, I don't have any financial interest on this. So, satisfaction guaranteed is in which form? Mohan sir said happiness. Happy, you can be happy in many ways. Patients, if you give concession, they are happy. If you give 6/6, they are happy. If they feel that they can see without glasses, they are happy. So how will they become happy is what we need to identify by talking to each patient. And then that has to be given to the patient to make them feel that they have received what they have been promised. So lenses and all look very good. If you show surgeon, patient and all, it will look very nice and all those things. But then there are different options. I don't want to tell about the options. Monofocal, extended depth of focus, and bifocal, trifocal, multifocal, whatever focal. But satisfied patient, when they are supposed to be satisfied is, patient has agreed for it, and you have also told that you will most probably deliver this. Then if those are the match, then they are happy. They will not tell anything back to you. You need not tell anything to them to convince that this was the best we could do and your eye there is something problem and all. And see, the visual acuity is definitely something which matters. Unless you stay with 6/9 and don't show 6/6 or something like that and then say, okay, you have all good things and all. As Mohan sir previously used to say, they have some places they have shorter measurement and all those and sit closer to the, closer and all those, And then contrast sensitivity, we don't know how people feel about the contrast sensitivity. See, some people come and say, now I have identified that my daughter-in-law's saree colors are like this. So I will also buy saree colors like this. So what is in their mind after surgery, what they're expecting? So Kapil Dev is fixed, Talaivar is fixed, but then there are so many majority of people who have things in their mind which they want to implement after getting back vision. So that is what we need to find out. What is the type of lighting where they are working at mostly, and will the photic phenomenon bother them at all? Why are you looking at light always? Don't look at light. I am not driving. Let somebody else drive. But I am driving. I need not. I am seeing it like this now. Again, you are telling that I will see like this again. I don't want it. So that requirement, please ask and show these kind of things. I show all these so that they will get an impression that something like this might be there. It may not be that very perfect regarding the quality of vision. So is it then just for the sake of showing some video, no? But then still, if they are coming very early, no video till now. So just like that. So if you think that everything is fine, and the thing is that perfect surgery is one important thing. No way out of a perfect surgery. So nice, soft and all those, you can see, do something different like rotate a lens inside, wheel it out and all those. Please don't try anything new or which you are not so used to in these kind of lenses patient. If somehow some dialysis or a PCRN happens, then you're stuck with not placing a lens. So not placing, you cannot place, you could not place, it's very difficult to You can tell that I had this thing, you have, we will do the, not very easy to convince, especially when they are paying 1.2, 1.5 lakhs and all this. So whether it can be implanted in all types of patients. So don't think that I write in many of my patients, no multifocals, no trifocals, and then send to this one. So such people are not given the option of this at all, or they're told this is not fit for you. That we have been telling, as sir said, look at conjunctiva and ocular surface. Nowadays we have realized that more than 50 to 60% of these old people who are coming for this one, they have some bit of ocular surface problem. So identify them, they go to dry eye clinic, identify, they get treated, and then come back after. Don't be in a hurry to operate. The other people, you please, morning you come, afternoon you operate, night you drive, whatever. That is fine. But if these are the patients, please evaluate properly, treat properly, and get the surface fine. And astigmatism, if you are treating or you have promised, then 0.75 astigmatism is also not acceptable. If it is a premium IOL, from 0.75 we need to treat. We need to use the toric lenses. And aberrations, as everybody was telling, look at all those and avoid that kind of patients. IOL, angle alpha, quite important. Especially when they are having this kind of trifocal, please look at the angle alpha and then only advise. So capsules, many patients have this posterior subcapsular, thick posterior subcapsulars. We don't know whether they'll have a PC plaque later. PC plaques later, we can tell them. I will tell them that it might have spread onto the capsule also. Then you might need a YAG earlier. So later the problem comes, whether it is because of the capsule or is it because of the cortical adaptation problem, whether they are not able to adjust properly. So please look at the posterior capsule very carefully on the slit lamp. Then this adaptation part, tell them that you don't tell them later that you are an idiot and you are not able to adapt, your brain is not good enough. You have to tell beforehand, everybody's brain is different and it takes time for some people may be fast, some people, but you might adapt, most people adapt and all those, and tell them that you are also intelligent. Then they will think about adapting themselves and they won't come and tell I am not able. Then they'll think that they are an idiot, rather than you telling them you are an idiot later. So the last person is this kind of a person. This kind of a person coming and sitting with 3 mobiles right on front of your table and then keeping, I want the best, doctor. Thing is, I can pay whatever, the best thing I shouldn't have this, I shouldn't have that and all. If you tell, then this kind of people, be little careful and tell that these are so many things will be bad. But the problem is, you again go down and see, then they will say, Bishop, I am not telling any thing, somebody senior or somebody big has this no kannadi surgery. So I also want no kannadi surgery. Whatever other things happen, I don't care. Such people are very good. Like you was telling politician, you put anything. So such kind of people are very good. But whether this stupi is, what does stupi mean, we have to identify. So affordability, see, if you push very hard and they get money from somewhere and then try to get a premium, then they will find fault with everything. They will tell that this thing is not good, that thing is not good, because that so much of money has been paid and some small thing they will balloon it up and so post-operative period also, again, they should not be coming back for this medicine, irritation and all those. So make the things hassle-free for them so that they don't keep on telling about smaller things, telling that this kind of so much money I gave you, this lens 1.5 lakhs and all. So understand this modest monovision is also a reality and suggest to people who are too fussy about the other photic phenomenon which you see. And it is premium when it is promised and is delivered with high predictability. Like Madam was telling, the biometry is very, very crucial. I do it 3 times. Once when they come, second when they are asked to come fresh on one day and just get it done in 15 minutes and go. And one more time when they come for the pre-op evaluation, which is a full-fledged evaluation. And perfect IOL still not available. As sir showed, there are many available. But this was old 2009 one. We have come a long way over this. Thank you very much for your patient hearing.
Thank you very much, Dr. Minu. As usual, full of humor and as well as very, very useful and practical tips in going ahead with multifocal practice.
Next talk is by Dr. Sony George. He's the regional, he's the center head at Agarwal's Eye Hospital, Kochi, and he'll be talking to us on how to offer multifocality to more patients.
A very good afternoon to all the delegates, and At the outset, let me thank KSOS for this opportunity and to all my co-instructors for the wonderful insights they have given into how to choose the ideal multifocal or how to customize a multifocal for the particular kind of patient. See, basically what I will be talking about will be how to offer multifocality for a larger number of patients. So in this, can I have the slides? Yeah. See, there were a few restraints which was keeping us away from giving multifocality to majority of the patients. One of the reasons was definitely the kind of photic phenomena, etc., which the patient used to have. And now we have come a long way from that, and we can offer with the newer EDOF lenses, etc., and even the trifocals coming out with a lesser loss of light in this particular kind of lenses. And also the economics, that also was very important. So these are the lenses we came through. So first was the economics. Now, with the Indian lenses coming into the market, we have very good lenses which you can offer to the patient. So the economic factor also has been taken care of. Photic phenomena, like I talked about. Astigmatism, obviously, you will need to give a toric lens lens as mentioned by Dr. Minu, anything above 0.75. And a functional working distance for near and intermediate. That's what we are talking about. Nowadays, people do not read newspapers at 30 centimeters. It's around 45 centimeters. And now I'm going to talk about 3 lenses which can extend the number of patients I can offer to the Indian multifocals like the Region and the Define from Indian companies and the Indian EDOFs. There are 2 new EDOFs which have come into market. One is the Swiss Phobe by the Apasamy, which is a surface modified, aspherically modified surface which gives EDOF properties, and also the Vivid, which is a EDOF lens by Orolab. It is a diffractive lens. And about the photic phenomena, like I said, if a patient who wants to drive and at the same time have a comfortable reading and intermediate, then I would advise Vivity to this patient. And AT Lara also will be an option, slightly less costlier option to the patient. And Panoptics and AT Lisa Tri also, like I said, have lesser photic phenomena. And if a patient doesn't drive extensively, I would still advise, and he wants to read, like a retired professor who drives, I would still give Panoptics or AT Lisa Tri. So the toric versions I talked about. And functional working distance, we have the Vivid, the AT or the AT Lara, the Vivity, and the Swiss Phobe. So Swiss Phobe is basically, like I said, aberration corrected with a central aberration correction which gives you good near vision, and the peripheral part which gives far vision. And here it has got an anterior refractive optic element and a negative aspheric design over the periphery which gives better depth even at low light conditions. And this is a comparable compared to the Minivel IOL. This is the kind of modulation transfer function which is pretty good. And in my experience, I have implanted around a total of 15 patients in both eyes, and the results have been pretty good. Yeah, this is the lens being implanted. You can see the polishing of the lens is excellent, and from that the aspheric correction on the surface is quite evident. This is the lens. Nowadays, they have also brought out the C-cartridge, D-cartridge kind of Actisov kind of injectors which go in through a 2.2 millimeter incision. So this is the lens being implanted. If you look at the surface, you will get a very, very good surface polishing which is evident. And this is how the lens looks post-implant. And I've got uncorrected vision of around, in 66 patients, 6.6, and 6.9 in around 34% of patient. This is the far vision. And the intermediate vision around 67% had N6, and 26.7 had N8, and 7% had N10. And the binocular uncorrected near vision versus the 66.7 got uncorrected near vision of N6, 27% N8, and 7% N10. Mind you, I always do a slight myopic residue in the non-dominant eye, which is also responsible for the N6, which is available in some of the patients. And none of the patients had any photic phenomena. And compared to the Technis eye hands, I feel this is much better. With Technis eye hands, I couldn't achieve N6 in any of the patients, N8 in 43%, N10 or less in 57%. So this features better than that lens, and even the magnificent lens, it is better than the eye hands, but then still I would place the Swisswap on a better platform. And this is the AuroView Vivid, which is called the continuous focus of vision. So this is what the normal, this yellow thing is the monofocal lens, and the other one, the bifocal or the multifocal, gives you better near vision, but more of visual distortions and slight intermediate vision. So this lens, this is the trifocal, which will give you more intermediate, and this is what the Vivid aims at. Minimum visual disturbances and better intermediate and near vision. So it has got a peripheral refractive zone, and the diffractive zone is in the center, which is around 3 millimeters and 4 rings. And refractive surface is on the anterior surface, and this is how it is. And either side 2.5 diffractive zone. So this gives much better intermediate vision and lesser photic phenomenon. And I have done around, this is a few months ago when I submitted the paper, around 5 patients bilateral implant, and this is how the lens is loaded. Basically, you just push the tip to fold the trailing haptic, the leading haptic over the optic, and then the implantation. This is the IOL which is implanted. You can see the rings which are seen very clearly. And this is the day 1 and day 2. This is 1 week, 1 month, and up post dilatation. The IOL is very well centered. There's no PCO. So here I get uncorrected distant vision of 6.6 to 6.9 in monoocular, and binocular it's almost 6.6 in all the patients. And the intermediate vision is N8 in uniocularly and N6 in most of the patients. And this is the near vision. One of the patients had N8, but the rest everybody had N6. And here again, I induce around minus 0.75 myopia in one of the eyes. Except for one patient, all the others didn't have any photic phenomena. And this has been talked extensively. The vivity is got the shifting and stretching of the wavefront, which gives better depth of vision as well as lesser amount of, I'll skip this because it's been extensively discussed. And so basically you have an extended range of vision, and patient has, the halo profile is almost similar to the accuracy of IQ, monofocal IQ. And again, so in my experience, again, I'll just skip this slide. I always do I don't have the privilege of having a femto to do the rexis, so I do a rexis marker. And you make sure, this is very important because ultimately the effective lens position is what is very important. So you get a perfect 5 to 5.25 millimeter rexis. Which is very important because the effective lens position is ultimately a very important factor in these cases. And this is the lens. It's got a central zone. And this is the lens being injected. It is just like the accuracy of IQ lens. but with a central area. So it's got a central 1 millimeter zone and then a plateau of 1.2 millimeter, totally making it 2.2 millimeter. And the central one shifts the wavefront while the plateau stretches the wavefront. So this is the lens being implanted and the cortical wash, which is very important. And these lenses, you can see the 3 rings in the center, the 2 rings in the center, plateau and the central area. You always have to go underneath and wash the IOL. And this is just to show that even these lenses can be implanted even in a case of a PC rent. I mean, sorry, rexis in discontinuity. Okay, in a torn rexis. This happened during chopping, but then I have implanted the lens and it is centered very well at the end of the procedure. And this is how it looks like. So these are the post-operative pictures. The lenses are well centered. So to sum up, I would say, if a patient who comes with where finance is not a concern, he wants to drive, he wants to read and use the computers and other gadgetry at a reasonable amount of expectation, then I would recommend Vivity to this patient. For a patient where there is an economic constraint, definitely I would offer the Vivid or the Supra for this patient. And like I said, if you ask the patient whether he wants the entire range of vision, there's no patient who will say, I do not want. So just like all the other speakers mentioned, we have to titrate the expectations of the patient versus our expertise versus the type of lens, and that will get us happy patients. And this is my data. Thank you very much for the patient.
Thank you, Dr. Sony, for that presentation. Due to paucity of time, we'll directly go to the next talk by Dr. Ilankumaran on my style of doing it. Over to you, sir.
I stand between you and the lunch now. After great talks by 5 people, actually I had to remove some of my slides there. Many of them were repetitions, so I removed, and maybe that's why Sony gave me this topic, my style of doing it. Thank you, Dr. Sony. Thank you, KSOS. Thank you, Dr. Srini, for giving me this opportunity. Let's remember nowadays that when we give a presbyopic solution, it's not just 6/6 N6 that we are looking at. It has to be good vision. It has to be good vision for all distances, near, intermediate, and distant intermediate and far. Not just 3, but there are 5 different distances that we work. But most importantly, there should be good quality of vision. This is what everyone was talking here. Now, how do we decide on a monofocal? Initially, we started with high add monofocals, which were concentrating, bifocals rather, which are concentrating on near, and then we shifted to low add monofocals, which slowly shifted the distance. I mean, multifocals, which slowly shifted the distance. Now, all these has been spoken about by my previous speakers, so I would just like to add a couple of words. Counseling. If there's one thing that will bail you out in any particular situation, it is the counseling. So the chair time the surgeon takes with the patient is directly proportional to the satisfaction, assuming that all other parameters are normal. Look at the tear film quality and the MGD. Commonly we miss in a large OPD. Definitely we miss this. We just keep looking at the lens. But there is a subtle tear film quality deficit. Maybe it's just a blinking deficit wherein the patient has to be taught to blink, or it could be an oil deformity where the adequate treatment has to be given, or it could be use of lubricating drops, stabilize this particular patient, and only then take him up even for calculations. Keratometry. How do we go about the keratometry? Very valid point what Dr. Meenu was talking about, a patient in, he mentioned everywhere, he forgot to mention Bangalore. Now Bangalore is a place where there's high expectation, but always, it's not 80% insurance, it's 100% insurance, almost 98 to 100% insurance. They expect us to do everything within that. So, any keratometer that you have been using for your monofocals, I'm sure all of us before going to multifocals or trifocals have used at least 200 to 200 monofocals at least. So, any keratometer that we have used, optimized, is good enough. Coming to the topography, is it good Answer is no. Do not use the SIMK values, particularly from a pentacam, to calculate the IOL power. So what is this good for? We will show it later. It is to show the generalized structure of the cornea, to look at, if you don't have any other equipment, to look at angle alpha and angle kappa, and also to look at the higher order aberration, just to give a hint and maybe confirm the cylindrical axis. This is what this pentacam or other topographers are used for. Best for keratometry is to use the optical biometer itself. Go for the best optical biometer that you can afford. All of us here started off with the old ultrasonic biometer. I still have my 21-year-old EcoRule 2, which I had shown in my previous presentation, still working, still good enough if it is done by me. So remember to do the biometry by the surgeon himself, or at least the senior most optometrist who has been trained by you. The same thing holds good for a counselor. Counselor should be sitting with you for at least 100 cases and then start counseling separately. Use the best of the formulas available. The best of the formula is also free. Remember, both Barrett, Hill RBF is available free on the website. Utilize that opportunity even if your machine doesn't have it. If your machine has it, great. What Dr. Mohan Rajan says, I always advocate in the practice. All my cataract patients go through this macular OCT. It happened after a patient where it was just a monofocal IOL, very dense cataract, missed out a macular edema. Macular edema, very small BR Vivo macular edema, we had missed it out and we had to go through a lot of problems with that particular patient explaining what had happened. So, the newer OCT, SS-based OCTs, have the potency to pick up macular pathologies even in dense of cataracts. So please utilize that. Look for higher order aberrations if you have the appropriate equipment, and for the angle, kappa and alpha. Alpha more important in these cases. There was an excellent presentation by Dr. Anaga and the other thing, why alpha is better than. Now you have this printout in front of you. What do you look at it? Number one, look at that value, cylindrical value. Now, you will know why I have chosen this particular biometry. One is 0.45, another is 1. Dr. Mino clearly mentioned, when it comes to monofocal IOL, we can have a cutoff of 1 dioptric cylinder. But when it comes to multifocal IOLs, trifocals, EDOFs, or others, my cutoff is anything above 0.5. 0.75 is what he said. That's what we do. Anything above 0.5, treat the cylinder. Now, next, look at this graph. That should have been first, actually. The graph should be proper. I'm not going into the details. The next thing what I look at is this particular thing. This is the macular point. Is it sharp like this, or is it blunted like this? Blunted may not necessarily mean a pathology, but is indicative of a pathology. Look for it. Next, come down, look at this IOL power. Compare it between the two eyes and compare it between multiple formula. Now herein comes the concept. If you have 2 biometers, please use those 2 biometers. Minu was telling 3. He has probably 3, or probably he repeats 3 times. But at least repeat it, or if you have 2 different biometers, please use those 2 biometers. Use multiple formulas. Deliberately, I use the slide of KSOS president. If given a choice, which formula to use, the higher the variables the formula uses, the better the formula is. So obviously you will know that the 5 variable and the 7 variable formulas are better. 7 variable holiday 2 is not freely available online. It's available only to IOL master users, but Barrett 5 variable is available. Now what do you see on a pentacam? Again, I reiterate, don't use these SIMK values. The first one, don't use these SIMK values. But what you should see is this. Is it regular? Are there any areas which could have, probably your optical biometer would have missed out? Look at localized areas of thinning and then look at those values to note the angles. Anything more than 0.4, I would not use. Finally, again, this should have been the first thing to be seen, whether this particular pentacam has been taken properly. A simplest thing is to get a cataract, if you don't have a pentacam, to ask your friend to send you a cataract workup and look at these values. Along with that, look at the aberrations. The front surface of the cornea produces the maximum aberrations, but sometimes, look at this higher order aberration. It will definitely be different. So take the total corneal aberrations, particularly in cases of refractive surgeries, and then go ahead with it. EKR value, I don't want to go too much into this, paucity of time. Just make sure that this particular graph is tall, sharp, not scattered, to have the best of the results. Again, I reiterate, an OCT like this looks very much normal, but there is one particular sign we have to look for, V to U sign. The macula, there is something. This is early age-related macular degeneration. Warn these patients. Not that I do not avoid multifocal or trifocal in these patients, but I warn them and prefer to go with premium monofocals or enhanced monofocal. Look at this angle. Okay, we don't have a eye tracy. How do we go about it? If you have a pentacam, utilize it. If not, IOL Master 700 also has this function. None of this is available. Even 20 years back, we knew this concept. Only thing we were not applying it. How were we doing it? Just throw a torchlight, look at where it is reflecting on the cornea. You will have a rough estimate. May not be a proper estimate, at least a rough estimate. Something like this, utilize. You can go ahead. The first one, go ahead with the multifocal. The second one should not be. I'll make it fast, sorry. Intraoperatively, Dr. Minu Mathan showed a video. What I would like to emphasize, complete overlap of the rexes. Make sure that the two Purkinje images also overlap, and always place this lens vertically so that you can make a little bit of nudging movements towards the nasal side if necessary. Now, how do I differentiate? I don't want to go into the brands. I don't want to go, all the technology has been spoken about. In fact, some of them, some of his slides I have to delete.
Yes.
Avid, last slide. Avid, just one more slide. Avid reader, trifocal, otherwise EDOF. Safest bet if you are starting off, enhanced monofocal would be better. How do I optimize between the two eyes? Always operate the non-dominant eye, either on target or 0.5 myopic. 0.5 myopic if I'm using enhanced monofocal, and then use that optimization for the dominant eye. Thank you, KSOS. Thank you, Dr. Sony. Thank you, the scientific committee for this
Thank you, Dr. Ellen, for that summing up of the whole talk. And this brings us the end of this session. And I profusely thank all my guest faculty, Dr. Mohan Rajan, Dr. Chitra, Dr. Ellen, Dr. Minu Mathan, and Dr. Sandhya.